family, it's me, Narisha Shay. Welcome back to my channel. So today I'm going to be talking to you guys really quick on my way to work. Right now it is about 9:30. I'm going to get me some Starbucks. My overall plan was to get on here and give you guys like a day in the life or a week in the life video, but unfortunately I haven't been able to start working by myself just yet. This is week 3, and because the last time I worked at the hospital that I work at now was less than 180 days ago, I thought that the process of the onboarding and everything would be a lot more smoother, but I haven't even been able to clock in for like the first week. I was having trouble with my access to, you know, our overall computer system, like how some people have Epic, some people have Meditech and stuff like that. I haven't had like full ability to use certain things, so you know, it was just like a mess. It wasn't like a bad mess, it was just the fact that, you know, I wanted to do things on my own and take full patient loads and stuff like that so that I could get a feel of what everything will feel like, especially because I'm not a new nurse and I don't get the privilege of, you know, orienting for a month and a half or 2 months or whatever. I get a, you know, I come in, I've been doing this for 3 years as a nurse, and now I come in and I get 2.5, 3 weeks, well, really for real, 3 weeks of orientation, which is fine with me. But now we're doing it backwards. So the first 2 weeks, I basically was getting like my patients and everything, and I was orienting with my friend that I told you guys about. I was with her a few times, and it really just depends because her schedule is not like mine. She only works 2 days a week as a PRN nurse, and I work 3. But you know, that extra person that I was with, you know, either taught me some of the same things or taught me something different. Of course, that's how it's always going to work as a nurse. But of course, also as a nurse, you take what benefits you best, and as long as it's within your scope of practice, you can do it. So yeah, with that being said, I was basically getting my, you know, my nursing skills down, like making sure that I knew what to do with this, making sure I knew what to do with that. You know, I've had trach patients since I started there. I've had peg tube patients since I started there. I've had, you know, patients that I had to start IVs on, patients that I had to give blood to already. So it is what it is, like the same basic nursing stuff. The patient to nurse ratio so far, or nurse to patient ratio so far, it was like 1 in 5, or like 1 in 7. And because, you know, for the most part, I was either taking half of the patients when I first started, or like a few, you know, some random days I would just be like, all right, let me just take the full 7 patient load. Then if it was a lot easier when I had like, you know, 1 in 3, and then the other person had the other 3, if we had 6 patients or something like that to split between us. But like if I had like 1 in 6 or like 1 in 7, you know, the only thing that would change honestly is that first med pass. The first med pass is normally at 9 o'clock. In my facility, you can pass meds an hour earlier. Of course, unless it's a narcotic, you have to wait until you get to the exact hour to give that medication. That's like worldwide. But for the most part, the first med pass is just always the hardest. As long as you're done with it before 10 o'clock, you're good to go, because you don't want your meds to be 2 hours off. So me personally, I start pulling my meds around 7:30, and then I just go straight into rooms at like 7:50, because by the time I finish scanning everything, and then, you know, by the time I go in, do an assessment, finish scanning everything, it's already like 8:05. So like I said, you can do things an hour early. So if med pass starts at 9 o'clock and I, you know, scan my meds and everything by 8:05, then I'm already within that time frame. So I like that. By the time I'm actually done with my med pass for patients on a 1:7 nurse to patient ratio, it's probably anywhere between 9:20 and 9:30. I'm usually done with a full med pass before 9:30, and that's not like me being, you know, inadequate or anything like that. For the most part, I go in, I let the patients know like, hey, you know, I got this med for you, blah blah blah. And sometimes I may have to go to a different Pyxis to get medication that probably wasn't in the other Pyxis, but I love using Pyxis. I miss using the Pyxis machine because it literally on the Pyxis machine tells you the times that these medications are to be given. And if it's a PRN med, it'll tell you like, all right, this is Q6 hours, and the last time it was pulled out was at 2000 last night. So you know now that if it's every 6 hours and now I'm on day shift, that was some time ago. I can give them this medication. I don't have to physically go into the computer. And even then, the computer systems are so great that when you go in and try to scan it, it'll say, no, you can't scan this because it's an hour and however many minutes early. You can't scan it. You're not finna scan it. You're not finna get it to the patient. And I appreciate that, because that helps with a lot of medication errors. It is ultimately your job as a nurse to make sure that you ain't messing that up, like you paying attention to that anyway. But systems like this, you know, the Alaris, when you're using the Alaris for you know, drips or medication administration through IVs, I love that, you know, because that also helps with medication errors. I like all of that kind of stuff that helps us as nurses, because at the end of the day, we are human and you can make human error regardless of the situation. But yeah, so just to give you guys a quick rundown, like I said, of a typical day. Like I said, today I'm going to be doing some education stuff, so I'm not even going to be at work all day. I'm supposed to be coming to work from like 10 to maybe 2, and then at 2 o'clock when I leave education, I'm probably going to go over to my building and do a few online health streams. I don't know if a lot of hospitals use HealthStream, but I love HealthStream. It is what it is. It, you know, some stuff you can skip through, some stuff you can't, but ultimately it's just the education portion of your job. So first I come in and I get a report from the off-going nurse. You're supposed to do room to room change the shift report. Cool. You go in, you let them know who you are, you get like a better feel of them. Of course, at that point you want to do the quickest assessment. My biggest assessment is looking at their neuro status. Like when I talk to them and I say, hey, how you doing, I want to see if they have slur of speech, you know, if they have any facial drooping, anything like that, especially for the stroke patients. That's a quick assessment. And then I kind of just ask them like, hey, do they have any wounds or anything like that? And if they have wounds and stuff like that, hold on you guys real quick, but if they have wounds or anything like that, then I want to know where they at. And I ask where they at, because then if I have to do wound changes, I can remember exactly where their wounds are. Hi. Hello?
Hey, what can I get started for you?
That's what I want.
Anything else?
That's it.
Alright, examining another question. The captain vanilla, the 3 comes to cinnamon dolce, and then the crispy grocery. So, to eat.
Thank you. Alright. So I actually got to get my card out. Hold on you guys. Like I was saying, one of the biggest things that I like to do is make sure that I go in and I ask questions about the patients and if they have any wound care that needs to be done, because me personally as a nurse, it is common courtesy to be like, okay, well, they have a bandage because they have a skin tear or whatever the case may be. And then that way, you know, you can determine if you need to just bring a bandage in the room during, you know, during med pass and change it real quick, especially if it's a new wound. It may be saturated and you want to make sure that you keep it clean and intact so that it can heal within that time frame that they're at the hospital, because you know, you don't want to send them home with all these extra wounds that now they got to take care of too. You know, when you send them home, one of the biggest things is like, okay, like I sent you home on like more of a healed type of environment. Like, yeah, you're still going to need pain management and you're still going to need some type of home health care, but you know, I don't want to send you home and like, you know, you aren't doing amazing. Like I want to send you home and you're doing amazing, you know, free of wounds if possible, or at least wounds that could be open to air, whatever. But yeah, so I go in the room and I do like a quick assessment, the neuro. Like I said, I ask questions, and that's my neuro assessment. And then of course, if I hear anything about a person having like pitting edema or anything, or if what is that, or if a person has you know, a Foley in or something like that, then, you know, I'm paying attention to what the Foley, you know, the output of the Foley is looking like. If it's red tinge, if it's orange tinge, you know, most of the time it was like red tinge just probably have something to do with trauma. So like, even though you may have the little pull sector thing on the side of it, I don't even know what it's called. I'm finna be all professional right now, but even if you have the thing that clamps and keeps it from pulling, sometimes it can still pull. And people with Foley catheters don't even realize that, you know, it's pulling like that because you have something internally in you anyway. So it almost becomes, it's a foreign body, but it almost becomes like one with you. So the only time they can really tell is when they start having like spasms or something like that. Then you gotta be like, all right, well, let me see what's going on. And then, you know, you find out when you pull it out or whatever that maybe it has some type of, you know, sediment or something like that around it, whatever. But anyway, so I do that, and then I go and sit down at the computer. A lot of my patients normally has uncontrolled diabetes, so they have ACHS blood sugars. So you do ACHS blood sugars, you're going to check their blood sugar for breakfast, lunch, and dinner. Most of the time they get Lantus anyway because of their diabetic status, and they need like something long acting, so they're gonna get that regardless. But you know, when you go in the morning, our PCTs come in earlier than us, so they already start getting on it with the blood sugars and the blood pressures and stuff like that. One blood pressure every single shift, so they get 2 blood pressures and 1 24-hour rotation, because like I said, we do 12-hour shifts there. And so I go down and I look at all of that stuff. I make sure their labs look all right. If it's something that's low, critical, you know, or high, cool, as long as it's not on a critical level. And then not only that, but the doctor gets informed about that kind of stuff anyway. So that's just like with one of my patients that I had to give blood to. Like I told y'all, his hemoglobin in one day was like 7 point something. And every hospital has their own way of doing whatever when it comes to transfusion. But the very next day it had went down to like 6 point something. So, you know, his blood pressure was all over the place and all this other stuff. So we was just like, all right, well, let's just give him a blood transfusion. So yeah, on that, that's that on that. But yeah, I mean, so I go and check their labs, I go and check their blood sugar readings, and I go and check the morning meds that I pretty much have to give to them, and I check their blood pressure. I have to make sure that, you know, it's a lot of people that are on these high level blood pressure medications, and as a nurse, you always want to use your clinical judgment. It's gonna be up to you regardless, because you are a healthcare professional. And if some shit hit the fan, they're gonna start with you because you administered it, and then they'll go to the doctor. So yeah, that's neither here nor there. But anyway, I go ahead and I do all of that, and then I start my med pass. Like I said, by 9:30, I'm pretty much done with med pass. I might go and take me a little quick breakfast break. As a nurse that works 12-hour shifts, you're supposed to have 1 30-minute break that you clock out and 2 15-minute breaks. You don't have to clock on your 2 15-minute breaks. So I take advantage of my 15-minute break to go eat some type of breakfast and to take any of my morning medication or anything like that, because y'all know I'm on blood pressure medications, and I don't really like to play around my blood pressure medications like that. I don't like to take no medication unless I ate something or drank some milk or something like that anyway. So around that time, I go and do that. I already took my vitamins for the morning, so I don't worry about that. And then I come back and I start my charting process. And I normally chart up until, from like, if I'm done with med pass around 9:30, then I chart basically from like 10 to 11:30, because around 11:30 is when I'm supposed to give my next set of ACHS blood sugars, if insulin, if they need insulin. So I'll go down the line and check the people that have ACHS blood sugars, and then if none of them need it, then I'm gonna keep charting. I just keep charting for the day. Because at that point, I've either seen them transfer, I've seen them do some type of hygiene for themselves. A lot of them like to ask me like, well, while you're in here, can you just, you know, walk me to the bathroom, or, you know, can I brush my teeth real quick? And that's me seeing how they transfer for the day. That's something that I have to chart on. You know, and of course, while I'm talking to them, I'm already getting their alert and oriented status, their plan of care status, stuff like that. That's all stuff that I chart on. Basically, for the most part, I'm making sure that they're good. And, you know, if I didn't see them fully independently transfer from the wheelchair or whatever, that's what I'm charting on. So I go in and do as much charting as I can. If I have 7 patients, the morning time, I probably do about 3 or 4. I probably chart on about 3 or 4 of them. Hold on real quick, you guys. I got about 10 minutes to get to work anyway, but it's no real rush. So yeah, one of the biggest things that I do at that point in the morning is start charting, and I chart up to, like I said, about 11:30. At that point, I probably got like 3 or 4 people out the way when it comes to charting, and then I have a little bit extra time to you know, just focus on what I need to focus on. And then, of course, my next med pass is around 2 o'clock if I don't have any insulin to give, which is never the case because I always have some type of insulin to give. But then I go back and I start charting. And then around 2 o'clock, I pass the 3 o'clock meds. So that is a much lighter situation. If I start around 2 o'clock and pass the meds, that's for 3, I'm done by 3. So that's like an hour process, if that, 2:30, 3 o'clock. And then I will take my actual 30-minute lunch break, which, by the way, is my favorite part of the day. So yeah, I take my 30-minute lunch break, and I'm done around about 3:30. If I haven't finished with charting, of course I finish charting. And I'm not gonna lie to you guys, if I am done with everything for the most part up until around 4 o'clock, because the next med pass is going to be 5 o'clock meds, so around 1600, that's the last thing that I gotta worry about, unless somebody wants some, you know, PRN, narcotic meds, something like that. I'm answering call bills and I'm studying. It just is what it is. If I have to do anything else past that, then it's probably gonna be like a treatment or something like that. If my patients have any type of like I said, wound care changes or something like that, I'm handling that. If it's an emergency, I'm handling that. But other than that, if it's like the rest of the day is pretty much carefree, I'm doing what I gotta do for my patients. Really, so you couldn't let me in? I swear, people in Florida, they are just mean and rude, child. They do not care. So basically, I go ahead and I make sure that everything is looking good before I start even looking at study material. As of recent, it's just been me trying to, you know, do my health streams and stuff like that. But because I have a final coming up this week, when I find downtime that, you know, does not involve anything related to patient care that is not, you know, like me taken away from them in their situation, a lot of them are literally tied up in getting therapy, physical therapy, occupational therapy, speech therapy. So these therapists pretty much take them from us all day. And then, of course, like I said, once they're done, the therapists are usually done around 4 p.m., no later than 5 p.m. And at that point, that's when you'll start getting a lot more calls from your patients, because now these physical therapists work them the hell on out. They worked them out, and now they want their meds. They want to be in bed. They're tired. They're just, you know, aggy. So, you know, you give them what it is that they need, and that's it. But yeah, schoolwork in the hospital setting for me, I swear to y'all, schoolwork does not come before the care of my patients. But if I have downtime, I am going to study. I will pull out, you know, some of my paperwork, and I'll start studying. So yeah, I mean, that's just a regular typical day for me. But like I said, as far as today and the rest of the week, I have to finish a lot of stuff dealing with education so that I don't have to worry about, you know, anybody clocking me in or clocking me out. I can do it myself, and making sure that all of my systems are working, because when I'm alone by myself, I'm not going to expect anybody to just come out of the woodworks and help me. So that's that on that. Alright, so yeah, let me get ready to go. I will see you guys later. I did receive a lot of feedback from you guys recently. I'm literally responding to some messages. I don't even know how YouTube be working sometimes when they don't even inform me that somebody has like sent a comment on like my older videos. But I try my best to go back and just literally look through everything. And then if it's just like a message that I didn't respond to or put a heart on the side of it, then that means that I didn't acknowledge it. So I kind of just go back. And if I've just recently responded to you guys after like a month or so, it's because I didn't get the notification. So of course, like I said, I feel that it's my due diligence to go and let you guys know that I saw your comment and I responded to your comment in some type of way. It don't matter what video it's on. So if after a month or two, like I said, that you just now getting some type of notification, then that's why. So anyway, let me go ahead and go to work. I will see you guys next week. And all the video requests that you guys have asked or asked about, then I'm going to try my best to compile and figure out how I'm going to do it, because some of y'all want to see some of y'all want me to talk about my house. and how I went about getting my new house. Some of you guys want me to talk about my experience in the military, like, and this is far-fetched from things that's going on with me in nursing, but I do understand that, you know, I give my viewers what it is that they want to see. So I try my best to be as open as possible with my life. So, and then, you know, some people might want to take the same route as me. So yeah, I try to be transparent. But anyway, I'll talk to you guys, like I said like 5 times now, but I'll talk to you guys later, and I hope to hear from you soon. Rate, comment, subscribe.